arm throwing. In other words, the dominant arm is almost always larger in circumference. And in pitchers, it's much larger. Tennis players, you know those crabs that walk around with the big arms sticking up, or the leg, whatever that is. That's what these pitchers look like. Their arm is markedly enlarged. But all this takes time, and it's a slow progression. And eventually what you get is atrophy, obviously, because they cannot throw anymore.
Yeah, here you can see the edema again on the sagittals, and you can see that there's quite a bit of edema in the medial epicondyle, and it looks irregular. There might even be like a stress, like some fracture. No, I don't think that's a fracture.
So this is a relatively early phase where you're just getting the edema pattern and loss of the normal fat signal.
You get, don't you get some swelling, John, and then the separation starts later. I think that's how it goes.
Yeah, I don't. Typically, what I've seen on MR is the first thing that we see is actually edema within the epiphysis,
right?
Which is the signal changes we're seeing right here, and then I start seeing kind of, and sometimes that's associated with edema in the growth plate, which we don't see here. But usually then the edema of the growth plate comes next, and then you start getting the separation, and finally the fragmentation.
Yeah.
Okay. Jennifer, what do you think of this case? This is a little older individual who is a baseball pitcher.
So we can see here that his ossification centers are much larger and more well developed. And there is a little bit of increased fluid signal intensity along the medial epicondyle, along the physis, compared to the other physes. So I'm concerned he may have some injury. Oh, I see there. Okay. So there's actually some mild displacement or separation along the physis with increased fluid.
Right, and you've lost fat signal within the epiphysis too, right?
Mm-hmm. Yes.
And here's the sagittal images showing all the edema within the bone there, which is abnormal, a little soft tissue edema next to it.
The epiphysis is hypertrophied.
Yep, that too. And here are the axial images. What do you see on the axial images, Jennifer?
Okay, so here again we can see some mild widening of the physis, especially posteriorly. You can see that fluid signal intensity cleft, and again we can see loss of the normal marrow signal intensity.
Yeah. So again, this is little league elbow. Now, if you catch it in the early stages, it can heal fairly rapidly within a few weeks. Obviously, the more advanced it is, the less fully it can heal and the longer it takes. 16-year-old, a little bit older yet.
The 16-year-old male baseball pitcher with medial elbow pain. So the medial epicondyle, it may look like, looks like it's not fused. Like at this point on this age, this should be fused.
Right.
So it never fused. There's some spurring. There might be a little bit of fusion, but there's separation, like basically, and there's all that soft tissue edema kind of over it. So it's just kind of chronic non-fusion of the. Yeah, now we can see a significant amount of edema within the non-fused epiphysis, as well as within the humerus and all that fluid undercutting in between.
Don't you think this is a little separated?
Yes.
And you can also see that there's a lot of injury to the ulnar collateral ligament here as well. And then you can see also the other thing that we talked about is you can see edema within the proximal flexor muscle. Here, this is the superficialis with a little bit of edema actually within the muscle. And then there you can see the clear-cut separation here, as John was.
Well, what happens there is that all the tissues adjacent to that injured area gets edema. And I would imagine that other parts of the elbow is probably a bit uncomfortable too, higher up and lower down. Because as I remember examining these kids, they were sore up and down the medial aspect of the arm, or I should say upper extremity.
So this is a 15-year-old football quarterback, had pain for 3 months after an injury. You can see that the medial epicondyle is avulsed and proximally retracted a little bit. There's a lot of edema there, and I'd like to see if the ulnar collateral ligament's still intact, but I doubt it.
Jennifer, what do you think of this one?
I wouldn't say that's dislocated. It's fractured.
Yeah, you're right. It's basically a fracture.
It's fractured and avulsed.
Yeah. Okay, Jennifer.
All right. So on this single image, I don't see the medial epicondyle ossification center very well. There is a lot of edema surrounding the proximal ulnar collateral ligament.
Yeah, and then the muscle there. This is also a patient with little league elbow. All right, Michael.
Okay, so it says little league elbow, and we see kind of edema at the interface, I think, of the ulnar collateral ligament and the epicondyle. So there's edema right at the interface of the medial epicondyle and the ulnar collateral ligament undercutting. So at least partial tear, or sprain of the ulnar collateral ligament, and it looks like there also might be a partial tear of the common extensor as well. I mean, common flexor. Sorry. Mm-hmm.
Maybe some tendinosis there.
Well, I don't know what you mean that there.
Yeah, so I think what we're seeing here is the increased intensity at the origin of the common of the ulnar collateral ligament. There's a little bit of increased signal intensity at the origin of the common flexor tendon, so some tendinosis there. The main problem here, however, is
this is an older patient, isn't it, John? And
yeah,
and you have periosteum upper above the epicondyle. That's kind of
So this
avulsed.
is really a chronic partial tear of the ulnar collateral ligament. I don't really like chronic sprain anymore, but a lot of people still use that. But it's really a chronic partial tear of the origin, and this needs to be handled just like it was a full tear, and operated if for the same criteria. Most people who are non-athletes with full tears don't need operation, but athletes who want to continue playing often do better with the time procedure.
So this is a 17-year-old pitcher with decreased velocity. Looking at the medial epicondyle, you can see that there's increased signal at the ulnar collateral ligament attachment, and there's also some stress reaction at the medial epicondyle. So I would be worried about a partial tear and also stressed injury.
So traction injury or trabecular bone injury of the medial, like you said, loss of
17-year-olds almost mature.
Okay. and that we can see that at least part of the ulnar collateral ligament is intact, but this isn't a normal ulnar collateral ligament with some increased signal intensity here. So this is a high-risk case. If you actually look elsewhere in this particular patient, there's actually a sprain of the supinator muscle. And then if you look elsewhere, this patient also has extensive bone edema within the olecranon, which we see there, as well as edema. This is in the area of the supinator injury, chronic stress injury of the olecranon. And these are all overuse injuries in the throwing elbow, which
Is that olecranon hypertrophy, John?
I don't think so. I think it's just edematous.
Okay, well, that causes the swell.
No, it doesn't cause the bone to swell. But I mean, over time, I guess it could. But olecranon hypertrophy's not really been described in this syndrome.
What I'm looking at is right behind the cornoid process, I mean trochlea, that part of the olecranon is really close to that trochlea, almost smothering it. And that's right in that area, yeah. There's no space left there. So it looks like it's swollen, and I don't know.
Yeah,
I'm not a radiologist, obviously, so I'm
the bone is a rigid structure, so I don't really think it swells unless it's fractured or you got a mechanical disruption of the bone. But here I think we're just partial voluming the joint space, and we're just not seeing the fluid there.
Periosteum can swell.
Well, there's no periosteum here. This is cartilage here.
Yeah, articular surface.
Okay. Let's see. Let me see. Let's see. So these are common locations where you see overuse injuries in these players that you need to look for and comment on, especially for pitchers. This olecranon stress injury is common. I think we already saw cases where if you don't allow it to heal, it can go on to actually a displaced fracture. Okay, Jennifer.
So this is a 15-year-old baseball pitcher with increasing elbow pain, and we can see here the medial epicondyle. There is some fluid signal intensity along the physis, and his physis should be closed at this age. So I'd wonder how long he's been playing baseball and if this is more acute or how long this has been going on. But this is at least a traction injury. And
Jennifer,
yes.
It doesn't have to be closed necessarily at 15. It varies from kid to kid.
Thank you. There is some fluid signal intensity and some mild edema surrounding the physis.
Right.
So I think he should be placed on rest for a while.
And if you look closely also in this area, we blow that up, this is actually abnormal increased signal intensity within the growth plate. This would be more cartilage, and this is more fluid signal intensity, just as you said. And then here, this is a subchondral edema on the posterior medial aspect of the humerus, and that's where you get changes from posterior impingement. And if we continue to look in this player, we can also see that there's a lot of edema within the olecranon. So this is another player who has a lot of the characteristics findings we see in overuse in these young pitchers. So these are the findings really to look for, and alert the referring physician that these patients are at risk for failure.
The 9-year-old baseball player with increasing chronic pain, history of MRI showing radial head edema. So let's see. Looking at the radial head, I mean, it looks like there's a radial head ossification center. Like, I'm wondering if that's almost kind of like what you just circled, like if that's almost somewhat erosive. And there's like a, this kind of fragmentation of the radial head ossification, which
Looks like a fracture, doesn't it?
yeah, it's separated. You don't really get fragmentation of the radial head ossification like, say, like the trochlea. And there's a defect there anteriorly, yeah, right there. So I mean, like kind of a chronic stress fracture.
Yeah, it's kind of chronic overuse.
You can have a fracture from overuse just as well as trauma, i.e. falling down or something.
So this is a 20-year-old pitcher with medial and posterior pain. Rule out ulnar collateral ligament and posterior impingement. We got the skin marker along the medial aspect of the sagittal, of this coronal, sorry. There's definitely, looking at this ulnar collateral ligament, it does look thickened, but it is intact, yeah. I don't see the fat pad very well, but this could be a little bit too anterior. Looking at this, oh, I see on the medial aspect, is there some changes, some eburnation changes there? So we're looking, this looks like mild or early posterior impingement.
The other thing you need to look for with these diseases happens to be muscle injury.
Oh, yeah. So,
Especially strain as well. So, and it's easy to miss the muscle injury, and often the symptomatic injury is the muscle injury. So be sure to look.
Yeah, that's the most common. So, so actually what you're looking at is chronic situation in the medial, in the ligament, and an acute situation in the muscle.
Right. And if we look here as a coronal image, we can see the edema in the muscle there. Here's the edema there and there within the muscles. And that's a flexor carpi radialis strain as well, and a flexor carpi ulnaris strain. And there's just a sagittal images showing the muscle strains. So again, kind of thing. So basically, then in summary, the reason we get MRs in these patients is we would like to find warning signs early in these patients before you get X-ray findings. And the things to look for are bone edema within the medial epicondyle and also the sublime tubercle, loss of the fat pad with an intact anterior band, bone edema in the olecranon with intact triceps, and then muscle edema. Those are the kind of things to look for, as well as the posterior impingement findings. Let's see, who's next? I've lost track here. Jennifer, what do you think of this one?
So here we can see some marrow edema. It looks like in the radial head and the lateral epicondyle, and there's some fragmentation of the lateral epicondyle. Looks like it could be chronic overuse injury.
Yeah, so this was actually a valgus mechanism of injury with impaction here on this side with those bone injuries. Yeah. Michael, pediatric patient.
Is that head hypertrophy, John?
I don't know. I'd have to look at the other images to see, John. I think this was a relatively acute injury.
Okay, so radiograph. So pediatric elbow, of course. So I see a few ossification centers, the capitellum, the trochlea, which can be fragmented like that, as well as the medial epicondyle. I don't. I wonder if the radial heads are diffused.
There's the T1 image. Again, I think that could be normal. And then if you go to this
So if we go to the STIR image, we do see some increased signal in that region of the trochlea ossification center.
That's within the cartilage.
Yeah, with maybe, well, yeah, like in the whole early, so yeah, Panner's disease.
So the cartilage shouldn't have fluid signal like this within it. And if you do, in this location, Panner's disease is where you have traumatic injury while you still have a lot of growth plate before you really have a as well-defined ossification center. And what you find in these is the injury to the articular cartilage here. So Panner's disease is kind of early on, kind of like the 9 to 12 age range, where you get, and then over time, these patients will develop symptoms. Their x-rays may be pretty normal, but then over time, if this isn't allowed to heal properly, you'll start getting abnormal growth and abnormal ossification in this area with recurrent trauma. And then you start seeing the x-ray changes that looks like what's called Panner's disease. With MR, we can pick up that articular cartilage injury earlier and should warn people then to allow this to heal before they continue to injure it. Okay, this is a little bit older patient. What do you think of this patient?
So this is a 12-year-old female gymnast with increasing elbow pain. We're looking at the radial head and the capitellum. I don't know if there's a lucency and subchondral sclerosis and some remodeling of the capitellum there. And you can see there's quite a bit of bone marrow edema in the subchondral region at the capitellum. I don't know if it's, I'd have to scroll through this. I want to see if it's back.
So this is at a later age where you have ossification developing here. And then if we follow this over time, this is a couple of months later. So this is 3 months after the first study. What do you see on the plain films?
You can see a small ossification in the region of the previous injuries. I don't know if this is healing.
Or fragmentation.
Oh yeah, or fragmentation. And it's becoming more mature over time.
So this is the way it, as it develops, you get this is primarily a cartilaginous injury with some bone component at this stage, and then it heals with that bony irregularity, and it looks like a little bit of fragmentation in here, which at this age group is called Panner's disease. A little bit later, well, in adults, it'd be an osteochondral injury, but it has a little bit different appearance and was described at different times. And so the difference between an osteochondral injury and Panner's disease is really the age at which the injury occurs. And early on with Panner's disease, you may not see changes on plain films. This patient is a little bit older. If they'd been a year or two earlier, you wouldn't have had enough ossification here to be able to see it well on plain films. So that's what you look for with MRs, is that injury to the growth cartilage. And that's early on so that you can hopefully intervene and allow them to heal better. So Panner's disease is typically age 7 to 12 years. It's a valgus stress injury to the ossification center in that particular area. Now, as you get older, what you get is more of an adult type finding, which we call osteochondritis dissecans, or an osteochondral injury. Again, same mechanism. It's just that the bone is further developed, so you really have a bony injury rather than just a cartilage injury. So that's really the differences between the two. Okay, Jennifer, what do you think of this case?
So 12-year-old baseball player, rule out capitellar osteochondritis dissecans. It looks like there was a lot of edema and cystic changes along the capitellum, and it is adjacent to the subchondral bone plate. I wonder if part of that cortex is a little bit irregular, if there's some fragmentation. So I think this looks chronic appearing.
Yeah.
And
So,
could reflect sequela of OCD.
yeah, well, so now what we know, back when I was a resident, a lot of these Panner's disease and these OCDs in these young kids, there was a differential as to what the cause was. A lot of people thought that it was abnormal development. Some people thought it was avascular necrosis developing that location. I think it's very clear right now that these are traumatic injuries. They're from repetitive trauma. Knowing that, then we should intervene at an early stage, knowing that these are really traumatic injuries. Here we can see subchondral cystic changes, meaning it's chronic, and here we can see probably not a stable osteochondral injury with some fluid going deep to the fragment here, and there's probably already some flattening of the subchondral bone in this location. This is probably unstable articular cartilage right in through this area, and then we can see the big effusion, which is typical for these as well.
You mean they had x-rays when you were a resident, John?
They did. They had x-rays. They didn't have MR for these things, but we did have x-rays.
I'm teasing you.
Right. Where do you think there's the incomplete fracture?
More proximally is the capitellum. Or no, superiorly. Yeah.
I think that's just the
Now, what do you think is going to happen to this patient in terms of his pitching abilities?
Is this Jennifer's case?
Well, I would, in this case, since it's a later stage and there's subchondral cystic changes and there's that fluid cleft adjacent to the subchondral bone plate, usually when we start to see fluid clefts, that is a sign of irreversible damage. So I think this will progress and may develop early degenerative disease.
I agree with you 100%. This is over the water under the bridge, I guess.
Yeah, right.
Maybe water under and over.
Right. Okay, Michael, another 12-year-old.
Another 12-year-old, roll out capitellar OCD. So on the first image, I do see kind of that subchondral hypointense like kind of signal right there. I'm not sure if that's just motion versus seeing on it on the other image. And now we can kind of see there's this subchondral like cystic appearance in the capitellum anteriorly with some surrounding edema. So I see it looks just kind of like subchondral cystic changes surrounding edema. I don't see like fluid undercutting specifically. And I think the cartilage, so it looks similar like to that prior one without that fluid undercutting.
Okay.
Oh, that's.
Those all turned out to be the same case. I'm sorry. So why don't you take this next one?
That was an effusion there and almost like a cystic change.
So this one now we see there's a lot of edema in the capitellum, and it looks like there is a subchondral fragment which is slightly angulated and displaced. So this would be an unstable osteochondral fragment or osteochondral lesion. We'll see similar findings.
Okay, this was on 10/7/2011, and the patient came back a few months later, and this is what it looked like.
Okay, so now it looks like there's even more fluid, and there maybe is a little more separation of the fragment. That's worse.
What do you think about this guy's pitching?
Well, he won't be doing it for very long.
No, I think it's finished. And chances are, if we were to guess, it's the parents that pushed the kid in that direction. Because these are very painful conditions. I don't know how much aspirin parents fed them, or Advil or whatever, ibuprofen. Aleve. You can buy it over the counter. They were not able to in 20 years ago. You had to get it from the pharmacy, so the doctor had to interfere. But once the parents were able to buy the medication over the counter, they could get away with a lot more injury than before. It's a two-way sword when it comes to medication over the counter.
So chronic increasing elbow pain, previous tennis player. I see some eburnation along the medial aspect there, right there, and I'm worried about posterior impingement. Looking at the triceps tendon, I don't know if it's torn at the muscular attachment or, oh, okay. Is this, oh, I see. Is this fragmented? Yeah, it looks like it's fragmented. It looks like there's a fracture there, and it's probably just chronic impaction and fracturing.
Okay, so actually we thought that these might be loose bodies. It turned out that these were not loose bodies. These were calcification within the cartilage there.
There's the articular cartilage cause.
Right.
Yeah.
So that this is chronic posterior impingement. It's not quite as disruptive as some of the Major League Baseball pitchers because this patient didn't do it for as long or is in the same degree of stress that a Major League Baseball pitcher would have. Jennifer?
All right. The 15-year-old male with pain and popping after golf, rule out olecranon fracture. Well, we can see that the olecranon, there's fluid along the olecranon, but there's not a lot of significant surrounding edema.
You're talking about this?
Yes.
Okay, along the growth
think-
plate there, right?
Yeah, so I think this is just not yet fused. Okay, so we're looking at that. Gosh. I mean, it does look like there is an effusion and there's some synovial thickening.
So this is fat signal here, right?
Yes.
And then we have some, what looks like maybe some edema, and this is a fat pet contusion.
Okay.
There, from also from overuse and forceful hyperextension in that area.
That's getting pinched, isn't it, John?
Yep, it's getting pinched there, and it's producing fat pet. It's basically the elbow equivalent of Hoffa's disease or Hoffa's fat pet impingement. So it's not very common, but this is just an example that was pretty well documented that was it. Okay.
Okay, so I guess we see fluid within the joint. Like I think that's just a little joint effusion, but it does look like there's kind of thickening around the joint capsule, maybe. And then anteriorly, there's another. That's kind of low signal intensity on all images. So I'm wondering if that's calcification of some sort.
I'm going to look for those as well.
A 38-year-old prior MLB pitcher unable to straighten arm. On the second image, you can see a loose body at the within the joint space right there. Yep, probably, and then some fragmentation. Loose bodies there as well.
The olecranon won't allow it to extend either.
So this is fairly common in Major League Baseball pitchers. Notice that he can't fully, as John said, he can't extend his elbow. And this is just a large osteophyte that's developed here from chronic impaction over the years. He also has a loose body here and an osteochondral injury in this location. But these big osteophytes are common, and occasionally these people will go in and have these osteophytes removed. Again, as I said last time, the important thing is you don't over resect these, because if you do, you'll lead to shoulder elbow instability, which can cause a lot more problems than the impingement. Okay.
I don't know if you would want to remove that loose body. It looks like it's been sitting there forever.
Yeah.
So you remove it, you might get instability.
Hmm.
I don't know. It's a guess.
It looks like it's damaging the
Yeah, there's a kissing lesion, that's for sure.
Okay, Jennifer.
So here I can also see a low signal intensity fragment along the anterior joint space. I'm concerned this could be another loose body.
Yeah, so that's another loose body. Same patient.
Okay, so here we can see the donor site.
Yeah, so there's a radial head fracture. Good. And then muscle injuries, we've already seen some other muscle injuries. One I just want to point out here is an anconeus muscle strain. Any of the muscles can get strained, and just in athletes, these are very common injuries. So just before you close a case, it's best to kind of go back on the fluid sensitive images and just look at all the muscles, because these are often the symptomatic lesion. You can see a lot of chronic stuff that looks bad, but if they have a muscle edema, that's usually the cause of the immediate symptoms, and that's what the doctors are interested in. Okay. Okay, let's go and talk a little bit about nerves. So the anatomy of a nerve, it's a large structure. On the outside covering the nerve is the epineurium. On the inside, you have the fascicles, and there can be many fascicles in a nerve. Centrally, you have an artery and a vein, typically. And then around each of the fascicles, you have a perineurium, and then you've got the actual nerve axons here. And here you have there is the endometrium that's basically and the myelin sheaths, which are basically the
Endoneurium.
that's what I wanted. The insulation for the axon that's in the center. So that's kind of the way the nerves are made up here. What do we look for with nerve injuries with MRI imaging? Several papers have shown that you can divide these into high-grade and low-grade injuries. What you look for is the nerve size. When you have nerve injury, you get increasing in size, which you typically can see in high-grade lesions. You can T1 signal, you can get increased signal intensity in high-grade lesions. PD fat sat, you get increased signal intensity on high-grade lesions from the edema. You can get heterogeneity in the T1 weighted images with higher grade, and also heterogeneity in the protein density fat suppression. But it turns out that even all of these have been described in the literature. They have turned out not to be very useful when you compare MR findings with surgical findings and with EMG and other studies. What recent papers have shown may be useful if you look for perineural fibrosis, typically present in high grade, architectural distortion. So with high resolution imaging, you can see a normal distribution of signal within a nerve with the different the different fascicles. And when you when the signal intensity within the nerve, the pattern of the signal intensity gets distorted, so you can't see the individual fascicles very well, or actually groups of fascicles very well. That can be a good finding. And the way you typically do that is you have a PD fat set image and cross section to the nerve. If you go proximally and distally, you can see if the nerve is large enough and you have adequate spatial resolution, you can see the normal signal pattern within the nerve. And then when you get to the area of the abnormality, which is typically increased in size, what you'll see is a blurring of the signal pattern within the nerve, and that tends to be a more valuable finding than just increase in size alone.
Well, what the surgeons do is that compared to what the radiologists do, the surgeons do a little cheating, John.
Okay.
They have these microscopes,
Yeah.
and they can see things that radiologists cannot.
Absolutely.
So, in other words, the radiologist cannot dissect a nerve.
Right.
But what's interesting is even if you dissect a nerve, that doesn't mean that you can heal it after you fix it.
Yep.
That's one of the problems.
Yep. The other thing that's valuable to see is you get bulbous enlargement, typically proximal to where the lesion is, and that can be helpful. If you see discontinuity of the nerve, that's a useful finding. And then if you see skeletal denervation distally in the pattern of the nerve distribution, that can be very valuable. So typically these last four findings increase the possibility that surgical intervention may be helpful in the patients. Whereas if all you see are the upper five, that's not very, you may have an abnormality to the nerve, but this doesn't correlate well with whether surgery will be helpful or not. Okay, so let's go and now I have we'll have further talks with more detail about looking at nerves. Now, if you really had a lot of nerve injuries, you'd really want to do diffusion tensor imaging. There you can actually see if you have normal motion of water along the nerve. And that's even better at differentiating the different patterns of nerve injury, but we'll talk about that at a different time. Okay, actually, why don't we stop here and we'll start with the ulnar nerve tomorrow, okay?
Have a great evening, everybody.
Thanks, John.
Take care, John.
Have a good night.
Thank you.
See you mañana.
Mañana.
Diffusion tensor imaging in carpal tunnel.